A very good morning to the dignitaries on the dais, respected Emeritus Chairperson Sir, respected Vice Chancellor Sir, Pro Vice Chancellor Sir, senior faculty and heads of department, residents and my dear colleagues. On the behalf of the Department of Clinical Hematology, I welcome you all for the combined clinical rounds. And I'll be starting off with a brief departmental introduction. So the department was established in 2019 and now we have a full-fledged teaching department with 4 faculty. Dr. Lalit Mohan sir is Associate Professor, Dr. Priyanka Assistant Professor, and Dr. Aniruddha newly joined this year, Assistant Professor. We are proud to say that we are the first teaching program in clinical hematology in the state of Rajasthan, and the first batch has passed this year, and it's a new beginning for the field of hematology and for the growth of hematology in the state and in the country, and we are really proud of that. This is the current, this is the passing batch, Dr. Omkar and Dr. Disha, who have done us proud. And the current batches include Dr. Gaurav, who shall be presenting today, Dr. Vaishali and Dr. Vijeta. The services that we have been providing are covering both adult and pediatric hematology and covering both malignant as well as benign hematology. The bulk of the load consists of acute leukemias, myeloma, lymphoma, and amongst the benign ones, various forms of anemia, immune thrombocytopenia, undiagnosed or diagnosed pancytopenia, a lot of bleeding and coagulation disorders, which often come as consults also. We are handling close to 10 to 15 consults a day, largely ranging from cytopenias, coagulation disorders, a lot of ICU consults and surgical clearances as well. The flagship program is the hematopoietic stem cell transplant program, which we have been running since the year 2019. And we have had the steady growth in this, and we have been covering both malignant and benign indications in adult and pediatric patients. The OPD and IPD workload has shown a steady increase over the last 3 years, and we hope that the same trend continues. And this includes both new and old patients and also daycare admissions as well as ward admissions. Speaking of the ward admissions, the bulk of the inpatient work that we do comes in the form of treatment of acute leukemias, and this forms the most critical, most difficult, and probably the most rewarding also part of the work that we do. Most of the patients are sick at admission, have heavy transfusion burden, have a lot of infections. The initial induction admission can last for 30-35 days. A lot of these patients, or rather I would say almost universally, we are using peripherally inserted center catheter in these patients, and I thank the Department of Intervention Radiology who have been very helpful in this regard and in maintaining a good central venous access device program. The transplants and cellular therapy program has shown a steady increase. Last 2 years consecutively we have done 38 transplants each, and we wish this figure to go up to 50 in the year 2026. And with time we have been able to increase the complexity of transplants that we have been doing. So these are for all rare, including rare pediatric immunodeficiency disorders, all benign and malignant indications. We have done haploidentical transplants, and we have also started the CAR T cell therapy program at the center. It would be amiss to not mention the pillars of support that we have. So these are the 2 departments. If they are not there, our work stops right then and there. So hematopathology, who've been the main bulwark in helping us formulating the diagnosis. These are the guys who really help us in zeroing down what we are actually dealing with, and we don't consider ourselves a different department in that sense, that it's mostly a shared work. Diagnostics includes both clinical as well as lab parts. So for our peripheral smears, bone marrow aspiration biopsies, flow cytometry, coagulation needs, hematopath support is there. Transfusion medicine, again, one of the pillars, one of the strengths of our institution, and we've been really fortunate to have the wide range of blood products availability, all types of procedures like PBSC apheresis, plasmapheresis, and this is something that really helps us grow. Close to 1,000 bone marrow aspiration biopsies done per year, and with regards to the blood products, well, I don't even have the data. I think the IHBT department would have the data, but we are probably the largest consumer of blood products in the institution, and we are really grateful for their support. We have been like really, it's a pride moment of pride that 3 papers were published in reputed international journals in the last year. This is all the hard work of the residents and junior faculty. Papers on myeloma, transplant, as well as promyelocytic leukemia, which have, and amongst apart from these, there are another 4 more publications in national and international journals. A few unique activities. We have a strong community outreach program spearheaded by Dr. Lalit Mohan Sharma sir. Central venous access device workshops are routinely conducted under the leadership of Dr. Priyanka Soni, and we've been repeatedly training the nursing staff and the residents, and this has helped us improve the care of CVAD devices, PICC lines, Hickman lines, ports, and also leading to lesser complications. For pediatric patients, we have a separate ward on the 8th floor in the annex building, and routinely cultural activities have been held. We have to understand that these are really sick kids, but these are young kids as well, and the needs of their like wholesome intellectual growth are also important, as is treating them. Drug trials are also currently running under the umbrella of the department. We've got MOU signed with the Indian Pediatric Hematology Oncology Group, the Indian Society of Bone Marrow Transplantation, to which we send the data, and we also have collaborative publications. We organized the first Rajasthan State Bone Marrow Transplant Conference in the year 2025. We have taken the lead in that, and this is something that we wish to continue on a yearly basis. I would like to also mention a few other departments which play a very important role in our day-to-day work, which is nuclear medicine, radiation oncology. We trouble them a lot for providing us irradiated blood products, but they have been really kind and helpful in that regards. And we wish that the future growth of the department is also in this direction. We would like to start with total body irradiation-based transplant conditioning, again in association with the Department of Radiation Oncology. Universal leukodepleted and irradiated blood products for all hematology patients. That's something that we are working in that direction, and I hope it will be realized soon. We wish to have more multi-center collaborative clinical trials with the larger institutes in the country, because oncology clinical trials largely hinge on the fact that how many patients can you accrue and how much data can you generate, and that's something that we are working on. And in line with the vision of the institute, we would want paperless data keeping and long-term follow-ups which are completely electronic based and not paper based, and that will also help us generate a good amount of data. And today being World Cancer Day, the theme being United by Unique, it's a call to arms to move in the direction of personalized medicine, where each patient is treated not on the basis of a group of a diagnosis, but rather as an individual patient with their individual needs, and this is also something that we hope to emulate in the future. With this, I would like to hand over to Dr. Gaurav Ojha, a DM resident. He would be presenting today's CCR case of a 49-year-old male with fatigue and bleeding.
Thank you, respected sir. Good morning, respected dignitaries, teachers, and my dear colleagues. So the topic of today's CCR is a 49-year-old male with fatigue and bleeding. So this is a 49-year-old male, businessman by profession, resident of Jaipur, Rajasthan, who presented to our department in August 2024 with a chief complaint of fatigue with lethargy for 20 days duration, secondly black colored stool for 10 days duration, and thirdly gum bleeding for 10 days. History of present illness. Patient was apparently well 20 days back when he developed fatigue with lethargy, which was gradual in onset and progressive over 20 days, present throughout the day, worsens with activity and relieves with rest. The black stool was characterized by dark black tarry stool 2 to 3 times per day with no fresh bleed. The gum bleed was provoked primarily while brushing, which was mild in amount and stopped spontaneously within minutes without requiring any intervention. I would like to highlight the pertinent negative history. The patient denied fever, vomiting, weight loss or anorexia. There was no jaundice, abdominal distension or any other bleed. There was no history of cough, dyspnea, joint pains or rash. The patient had no abdominal pain, no postprandial or nocturnal epigastric burning, no retrosternal discomfort and no regurgitation. There was no history of recent travel, no prior history of blood transfusion and no known allergies. Past history. The patient has a 7-year history of type 2 diabetes mellitus managed with oral hypoglycemic agents. Additionally, the patient has been diagnosed with chronic obstructive pulmonary disease for past 5 years. Clinically, this manifested with seasonal exacerbations requiring inhaler therapy, typically once or twice annually during the winter months only. Notably, the patient has been symptom-free without treatment for the last 2 years. Patient was diagnosed with tubercular lymphadenitis 4 years ago and completed a 6-month course of anti-tubercular treatment. patient also underwent cholecystectomy for gallstone disease 2 years back. Moving to the family history, which was not significant, and regarding the personal history, the patient maintains a mixed diet and adequate nutritional intake. Sleep patterns are normal and undisturbed. Bladder and bowel habits are within normal limits, and the patient is non-alcoholic and denies any history of substance abuse or addiction. So, to summarize the case, this is a 49-year-old male who presented with a 20 days history of progressive fatigue, melena, for the past 10 days and episodic gum bleeding, also spanning over 10 days. From the past medical history standpoint, he is a known case of type 2 diabetes mellitus, COPD, and has a history of treated tubercular adenitis. He has previously undergone cholecystectomy for cholelithiasis. Now, any possible causes?
So, MD medicine residents, anybody? एक दो causes तो बताओ. No volunteers?
So now let's move to the possible differential diagnosis we considered in this case. Immune hematological causes included aplastic anemia, immune thrombocytopenia. In GI causes, we considered CLD with portal hypertension and peptic ulcer disease. Neoplastic causes included acute leukemia and GI malignancies. Finally, infectious causes like TB, viral infection and malaria. In this case, these causes are very less likely as there was no history of fever, no constitutional symptoms and no history of any weight loss. Examination. Pulse was 110 beats per minute, regular in rhythm, normal volume, normal character and all peripheral pulses were felt. Blood pressure was 121/79 mm of mercury in right arm supine position. Temperature was 98 degrees Fahrenheit. Oxygen saturation was 98% on room air and respiratory rate was mildly elevated around 23 per minute. On general examination, the patient was well oriented to time, place and person with a BMI of 28.7 kg per meter square. The key finding was pallor, rest, icterus, clubbing, cyanosis, edema, lymphadenopathy or were absent. On detailed examination of the individual sites, conjunctiva was pale. Oral cavity examination revealed active wet purpura over the buccal mucosa along with gum bleeding. Skin examination revealed multiple petechial spots distributed over bilateral upper and lower limbs. These were non-blanchable and non-palpable. Moving to the systemic examination, starting with the abdominal examination. On inspection, abdomen was not distended, umbilicus was inverted and central. A healed port scar of cholecystectomy was present. There was no visible peristalsis or pulsation and no dilated veins were visible. Palpation of the abdomen, there was no local rise of temperature, no tenderness and no guarding or rigidity. The liver was palpable 1 cm below right costal margin in the mid-clavicular line. It was firm in consistency, had a smooth border, a smooth surface, rounded border and moves with respiration. Spleen was not palpable. On percussion, liver dullness was present from the fifth intercostal space to 1 cm below the costal margin in the right mid-clavicular line, giving a liver span of approximately 14 cm. Fluid thrill and shifting dullness were absent, and on auscultation, bowel sounds were present and normal in character and frequency. Cardiovascular, respiratory and neurological examination were within normal limits. Now to summarize the case, a 49-year-old diabetic male presented with complaint of fatigue, melena along with gum bleed of around 10 to 20 days duration. Examination revealed presence of pallor, petechial rash on both upper and lower limbs, wet purpura in oral cavity, no organomegaly, and no lymphadenopathy. So now, based on the examination finding, our refined differential focused on mainly three main categories. In immune hematological causes, aplastic anemia and ITP were still relevant. In GI causes, as there was no clinical stigmata of chronic liver disease such as ascites or splenomegaly, so CLD and portal hypertension were highly unlikely. Peptic ulcer disease requires further investigation in the form of upper GI endoscopy, which I will discuss in the further slides. Acute leukemia still remained our primary concern, and GI malignancy were also kept, particularly those that can cause marrow suppression or infiltration. So now let me present the CBC finding, which showed anemia with hemoglobin of 5.9 gram per dl, with thrombocytopenia with platelet count of 15,000 per microliter. Mean platelet volume was also elevated. Peripheral blood film, RBC reduced in red cell mass, normocytic normochromic RBC with anisopoikilocytosis. Spherocytes were present, polychromasia were also present, few nucleated RBCs were seen. WBC was within normal limit and platelet was markedly reduced. Few giant platelets were also noted. Further workup showed reticulocytosis with 10% retic count. LDH was also raised. It was 680 units per liter, and coagulation parameters were within normal limit. RFT was within normal limit. LFT showed indirect hyperbilirubinemia. Rest all examination along with USG whole abdomen and pelvis were within normal limit. So after the initial assessment, we proceeded with immediate stabilization and management. Given the critical cytopenias, hemoglobin of 5.9, platelets of 15,000 with active bleeding, we immediately initiated transfusion support in the form of 2 units PRBC and 6 units RDP. Supportive medications include proton pump inhibitor for gastric protection, sucralfate for mucosal barrier support, tranexamic acid to minimize the bleeding. Simultaneously, we pursued targeted investigations. Upper GI endoscopy, given the peptic ulcer disease and GI malignancies as the differential diagnosis, we performed upper GI endoscopy in consultation with the gastroenterologist. So upper GI endoscopy excluded peptic ulcer disease and GI malignancies.
So Gaurav,
Yes.
with a platelet count of 15,000, would you still consider peptic ulcer as one of the possibilities? And it would be an added risk to do an endoscopy in a patient with low platelet counts, no?
Sir, actually the hemoglobin was also low in this case.
So that can be explained by the bleed.
Therefore, we thought, sir, we have to rule out the peptic ulcer disease also. And for doing that upper GI endoscopy, we provided all the transfusion support in the form of SDP before the procedure, and we have kept extra STB also if there is any chance of bleed. So, repeated CBC on day 2 showed increment in hemoglobin, but platelets were not increased. Immature platelet fraction was also elevated. It was 21%, which indicate increased thrombopoietic activity if the IPF is increased. Given our suspicion of immune-mediated cytopenias, we conducted immunohematological study which showed strongly positive DCT, 4 positive, and ICT, that is indirect Coombs test of 3 positive. ANA by IF was negative, and by vitamin B12 was within normal limits.
So Gaurav, you have a non-hematology audience. Can you elaborate what is the direct Coombs test and just general principles, and what is the indirect Coombs test?
Sir, in direct Coombs test, we test the antibody antibodies on RBCs, and in direct Coombs test, we test the antibodies on the serum of the patient. So, in any autoimmune hemolytic anemia, body generates auto antibody against own PRBC. So it attaches to the own PRBC of the cell. But ICT will become positive only after blood transfusion. Suppose a patient receives blood product from other patient, then the patient body will generate antibodies against those red cells which he has received. So this antibody is detected by indirect Coombs. This antibody is detected by indirect Coombs test, and the antibody which is formed by own body, it is detected by direct Coombs test. So the investigation allowed us to systematically exclude several etiology and focus on most likely causes. Peptic ulcer disease was excluded as upper GI endoscopy found no gastric or duodenal ulcers. Acute leukemia was highly unlikely as the PBF showed no blast. GI malignancy were also excluded by endoscopy. And in immune causes, aplastic anemia was highly unlikely as both LDH and retic count were very high. The strongly positive DCT confirms autoimmune hemolytic anemia, and elevated IPF along with thrombocytopenia suggested immune thrombocytopenia. So based on the comprehensive workup, we arrived at the diagnosis of Evans syndrome, that is autoimmune hemolytic anemia along with immune thrombocytopenia. The diagnosis was established based on following key findings. First, the PBF showed spherocytes and polychromasia, which is morphological evidence of hemolysis. Secondly, elevated retic count and elevated LDH, which is biochemical confirmation of hemolysis. And thirdly, and most importantly, Coombs test positivity. Both DCT and ICT were positive, confirming autoimmune hemolytic anemia. Fourthly, normal coagulation parameter excluded any coagulopathy. So as we know that immune cytopenias in older adults are less common. So, and Evans syndrome can be primary or secondary to some underlying malignancies, and to determine whether this was a primary or secondary Evans, we performed a whole body PET CT scan and bone marrow examination. Whole body PET CT scan showed mild splenomegaly measuring 14 centimeter, and there was no abnormal metabolically active lesion anywhere in the body. And to tell about the bone marrow examination findings, I would like to call upon Dr. Neha from the Department of Oncopathology to take the case forward.
Diagnosis of like immune hemolysis and diagnosis of immune thrombocytopenia, both of them do not require a bone marrow examination. That is quite certain, and as sir has mentioned, the increased reticulocyte count and increased IPF already suggests that the marrow is working well. The main reason for doing the marrow in this case was the odd age of the patient. Usually we see immune cytopenias mostly in younger patients, in females. It has association with strong association with underlying autoimmune diseases. But in the older patients, low-grade lymphomas become an important possibility, which can present as an immune cytopenia, but the main disease lurking within would be a low-grade lymphoma. For the sake of completion of the workup, like if you're not missing anything, a PET and a marrow was done, and both of them combined, we can conclusively say that there was no underlying low-grade lymphoma which could have been causing this. Mostly follicular lymphoma or a marginal zone lymphoma is something that we encounter in such settings, and they may not have any presentation, any symptoms of the lymphoma for many years, and the initial presentation be like an immune hemolytic anemia or immune thrombocytopenia. And it's not uncommon to see that a patient treated for AIHA or ITP 4 or 5 years down the line presents with the classical symptoms of a lymphoma, and then we can add 2 and 2 together and consider lurking in the background all along. So that was the reason for the marrow procedure. but not to confirm the AIHA and ITP, which already like with the blood investigations. Sir, melena would be, sir, in such cases we can have it like a more of a diffuse ooze from the upper GI tract, so not like a Yes, sir. Yes, sir. Yes, sir. For this patient, it could be a combination of two things. Sometimes what happens is a patient is having oral bleed. Some amount of swallowed blood might also render the stool black, and some amount of bleeding from the upper GI tract. So both of them combined can render the stool black. I agree that the ooze can be there from any part in the GI tract, but for this particular patient, the symptoms mostly correlated with a bleed or originating from the upper GI tract.
All these actually coagulation disorders, they present with mucosal bleeds, and especially when somebody is presenting with melena, it points towards the upper GI tract, and it's a diffuse actually mucosal bleed, and nothing much can be done except for correction of the coagulation disorder, which improves the patient. Of course, patient was given PPI therapy, so that actually probably heals the superficial ulcers. I do agree. I mean, the bleeding can occur from lower GI tract as well. But if you have seen on endoscopy presence of esophagitis and pen gastritis, so that can explain the presence of melena.
So after bone marrow examination and whole body PET CT excluded, marrow malignancies and secondary causes, the final diagnosis was primary autoimmune hemolytic anemia with immune thrombocytopenia, that is Evans syndrome. Following the diagnosis, we initiated first line immunosuppressive therapy along with comprehensive supportive measures. We initiated dexamethasone pulse therapy at a dose of 40 mg IV daily for 4 days, followed by oral prednisolone at the dose of 1 mg per kg per day. Supportive measures included PPI, sucralfate, tranexamic acid and blood transfusions as clinically indicated. Endocrinology consultation was taken for insulin management as the high dose of dexamethasone caused significant hyperglycemia.
Dr. Gaurav, can I ask you one thing?
Yes.
Go back to the previous slide. Now, with this kind of treatment protocol, do you think there is when you are going to give steroids for a longer period of time, and in a suppressive doses, do you think your idea of doing a bone marrow aspiration would be a prerequisite for doing this thing, in view of the fact that he had problems of tuberculosis also earlier?
No, sir. If the patient was young, suppose a child, then we would not have done the bone marrow examination, since the age of the patient was high, and to rule out the underlying secondary causes of Evans syndrome. Therefore, we did the bone marrow examination. Sir, actually the symptoms were for the TB point of view, actually there was no symptoms related to TB. There was no loss of weight, and the symptoms were present for only 20 days duration. That clearly the TB was unlikely.
So to elaborate on your point a little further. Sir, I rightly agree that giving steroids in a patient who might have an underlying malignancy would completely mask it, and like it might be discovered at a very late point, which would be steroid refractory. So often the protocol is that if we are using non-steroid based treatment like an intravenous immunoglobulin, at that point doing a marrow is probably completely unnecessary. But with steroids, we have this two-fold issue that if it is a and there is an underlying tuberculosis, it might flare up. If there is an underlying lymphoid malignancy, it might completely be suppressed and masked for like months or years to come. So I think doing a PET and a marrow at baseline like secures us in that fashion that there is no infective focus like active at that point. Also, there is no like lurking hematological malignancy. So it serves both purposes probably.
So supportive measures included PPIs, sucralfate, tranexamic acid, and blood transfusions. Endocrine consultation was obtained for insulin management. Course, we observed improvement in both hemoglobin and platelets count, indicating a favorable response to initial therapy. The bleeding got completely subsided. Concurrently, the patient's diabetes mellitus was well controlled on insulin therapy. The patient was discharged safely on oral prednisolone at a dose of 1 mg per kg per day and was followed up in OPD. The patient showed encouraging initial response to first-line immunosuppression as demonstrated by these trends. Looking at the hemoglobin response at admission, hemoglobin was 5.9 gram per dl. At discharge, it was risen to 9.8 gram per dl, and by day 14 of oral steroid therapy, hemoglobin reached 10 gram per dl. Initial platelet count was 15,000, and at admission it rose to 71,000 at discharge and 80,000 after 14 days. Importantly, this response was maintained during the slow taper of steroid also. By 3 months, we were able to successfully reduce the prednisolone dose to just 10 mg per day. Recurrence. As characteristic of Ivan syndrome, relapsing nature, patient experienced his first recurrence at 3 months when he was on steroid tapering. Hematological parameter demonstrated significant deterioration. Hemoglobin declined to 8.5 from previously 10.5. Platelet dropped to 30,000 from 80,000. DCT remained strongly positive. Hemolysis markers re-emerged. Retic count elevated to 10%, and LDH rose to 615 units per liter. Management required immediate therapeutic escalation. Firstly, steroid re-escalation. We increased prednisolone to 1 mg per kg to regain disease control. Second, azathioprine addition at a dose of 50 mg OD followed by 50 mg BD for steroid sparing effect. Third and most importantly, rituximab therapy. After comprehensive departmental board discussion weighing risk and benefits, we administered rituximab at the dose of 375 mg per meter square weekly for 4 doses. Response. Following the therapeutic escalation with azathioprine and rituximab, the patient demonstrated favorable hematologic response. Hemoglobin improved progressively 8.5 gram per dl at recurrence to 10.55 after 1 month of relapse. Patient showed robust response, 30,000 at recurrence, 85,000 at discharge, and 135,000 after 1 month. With sustained hematologic improvement, we initiated careful steroid tapering to reduce long-term toxicity of steroid. Azathioprine was continued and rituximab was given weekly for 4 doses. However, during the outpatient follow-up, we encountered a clinical challenge that required modification of our management strategy. Patient developed steroid-induced hyperglycemia with fasting blood sugar exceeding 250 mg per dl. HbA1c was also 8.2%. Additionally, there was concern about long-term steroid toxicity. To address this challenge, we decided to initiate accelerated steroid tapering, and the rationale was that Rituximab plus azathioprine combination was expected to provide the durable disease control. So second recurrence. After 2 months following rituximab completion, the patient developed his second disease recurrence. The lab findings were concerning. Hemoglobin dropped to 6 gram per dl from 10.5 and platelet count fell to 19,000 from 135,000. Both retic count and LDH were elevated, confirming active hemolysis. So we made several management changes. We immediately administered IVIG at a dose of 1 gram per kg for platelet rescue. We discontinued azathioprine, which had clearly failed. L-Thrombopag, which is a thrombopoietin agonist, was added at a dose of 50 mg OD. The steroid dose was again increased to 1 mg per kg and blood transfusions were given as required. Sir, with methotrexate has a in AIHA and ITP, methotrexate do not have any role per se, as far as I know, sir.
Methotrexate is not usually preferred in these indications. The common like steroid is the main it's the main workhorse here. But we use other immunosuppressive drugs primarily for steroid dependent or steroid refractory. The preferred drug is rituximab. The other oral drugs that can be used are azathioprine, mycophenolate mofetil. Sometimes cyclosporin also has some activity. Previously we have used a lot of dapsone and danazol, sometimes even chemotherapeutic agents like vincristine and bortezomib. So these are all designed to basically act on primarily the B cell system, except with cyclosporin, which is primarily working on the T cells. So these are the drugs that we commonly juggle between when we have a case where steroids are either not working or they are required at very high doses.
Sir, yes, sir. Nowadays, splenectomy is done very rarely, but it has a role in very refractory cases. That
for the event syndrome, even from the ASH, if we are going to treat refractory event syndrome, at least we have to try plasmapheresis. Then you start your treatment, because all the antibodies, which is mainly causing destruction of RBC and platelets, they are removed, and when you are giving treatment after the plasma exchange, they are more effective.
So now the hemoglobin and platelet trend. So when the hemoglobin and platelet got recovered, then the patient was discharged and transitioned to outpatient department follow-up basis. Over the next 3 months, we observed divergent hematologic trends. Hemoglobin showed initial improvement from 8.5 gram per dl at discharge to 9.5 after 1 month, peaking at 10.1 gram per dl after 2 months, indicating good control of AIHA component. However, platelet demonstrated a concerning declining trend, starting at 169,000 at discharge, dropping to 135,000 after 1 month, and further declining to 105,000 after 2 months. Simultaneously, patient developed significant steroid toxicity in the form of Cushing-Boyd phases, recurrent hyperglycemia, requiring insulin therapy. So we again started tapering the dose of steroid after 2 weeks of discharge. After 3 months, both parameters, that is hemoglobin and platelet, showed simultaneous decline. Hemoglobin fell to 9.6 gram per dl and platelet fell to 101,000 per microliter. Now third recurrence. After 3 months of relative stability with outpatient management, the patient experienced his third recurrence. He presented with severe bicytopenia. Hemoglobin dramatically fell to 5.9 gram per dl from 10.1 and platelet fell to 15,000. Lab study confirmed active hemolysis with elevated reticulocyte count of 13.5% and LDH of 610. So we immediately implemented maximal medical escalation. IVIG was repeated at a dose of 1 gram per kg. This time mycophenolate mofetil was added at a dose of 1000 mg BD as a third line immunosuppressant. Dose of L-Trombopag was also increased from 50 to 75 mg OD. Steroid was tapered and permanently discontinued this time due to intolerable toxicity including hyperglycemia requiring insulin and long-term steroid dependency concerns. Following the third recurrence and our therapeutic escalation, we again transition the patient to OPD basis follow-up with close monitoring. Over the subsequent 3 months, hemoglobin showed initial recovery rising from 8 gram per dl at discharge to 9.8 after 1 month, but then slightly declined to 9.5 at 2 months and 9.1 at 3 months. Platelet demonstrated a completely different pattern. Initial robust response to 130,000 at discharge, but then progressively declining to 109,000 after 1 month and 105,000 after 2 months, with a slight recovery to 120,000 after 3 months. During this period, patient remained stable clinically and we achieved better glycemic control after discontinuing steroids. Fourth recurrence. After 4 months of relative stability on maximal medical therapy in August 2025, the patient presented with fourth disease recurrence, and it was the most catastrophic relapse. He developed alarming clinical manifestation in the form of melena, wet bleeds in the mouth, and severe fatigue. Lab investigation again revealed bicytopenia. Hemoglobin dropped to 7.4 gram per dl, down from 9.1, and platelet collapsed to 6,000, only 6,000, down from 120,000. The markedly elevated retic count at 15.4% and LDH 330 units per liter, along with DCT positivity, confirmed severe active hemolysis. Coagulation parameters were within normal limits. So this timeline shows the patient's 13-month hematologic journey with 4 disease recurrences despite escalating the therapy. In August 2024, he presented with severe anemia and thrombocytopenia following dexamethasone pulse therapy and oral steroid. Both parameters recovered. First recurrence at 3 months from the baseline, we added azathioprine and rituximab. Omnacotil, that is prednisolone, was continued. Second recurrence at 5 months from baseline, we added IVIG and L-Trombopag. Third recurrence at 8 months from baseline, we repeated IVIG and added mycophenolate mofetil and escalated dose of L-Trombopag to 75 mg OD from 50. Now this is the fourth recurrence. So following the fourth recurrence with life-threatening bleeding, we again initiated maximal emergency medical management using combination therapy with 2 most potent agents. As the patient was off steroid, so we again challenged with steroid. High dose dexamethasone pulse therapy was initiated at a dose of 40 mg IV OD for 4 consecutive days. Simultaneously, we administered IVIG therapy at the dose of 1 gram per kg for 2 consecutive days. Concurrently, we continued mycophenolate mofetil and L-Trombopag. Insulin was also started for hyperglycemia. Gastroenterology consultation was again taken for melena, and they advised comprehensive endoscopic evaluation. Upper GI showed GERD with hiatus hernia and pangastritis. Colonoscopic findings were within normal limit. So the clinical course during this admission demonstrated severe refractory disease. Despite aggressive medical therapy, the patient had persistent active bleeding in the form of melena and wet bleeds. On clinical examination, tachycardia was present, but BP was stable and there was no fever, helping us exclude concurrent sepsis or infections. Serial CBC monitoring throughout the hospitalization consistently showed persistent anemia with thrombocytopenia. To keep the patient alive, we provided massive transfusion support in the form of 16 units PRVC, 12 units SDP and 10 units RDP. So, as we know that IVIG and high dose steroid may require approx 7 to 10 days to achieve peak therapeutic effect. So, therefore, we continued intensive supportive care during this observation period. Serial PRBC transfusions were given to maintain hemoglobin above 7 gram per dl. Regular SDP transfusions targeting platelets above 10,000 per microliter. Daily hematologic monitoring was done to detect early trend towards any improvement. However, beyond 10 days, we faced a desperate situation. The patient was continuously bleeding. There was no improvement in hematological parameter despite multiple PRBC and SDP transfusions. So, this clinical picture clearly indicated the refractory nature of the disease. So, here we observed only multiple short-lived hematological responses. High dose dexamethasone pulse therapy and repeated IVIG courses both showed no response. We escalated to multiple immunosuppressants including azathioprine, mycophenolate mofetil and even rituximab, all of which failed to control the disease. Given the critical situation, we convened a departmental meeting to discuss further options, and the consensus was clear: emergency splenectomy as a life-saving procedure.
Repeated kind of relapses. Did you go in for any virological studies? Because viruses like CMV and EPV are known to act as triggers in events.
If there was any previous viral infections, there was no fever, nothing, and normally in viral infections there are pancytopenia. The TLC is normal, and after giving this immunosuppressant therapy, the hemoglobin and platelet of the patient show improvement. Therefore, in viral infection, if we give these, if the bicytopenia is due to any viral infection and we give steroid or any immunosuppressive therapy, then that bicytopenia will not resolve.
No, I think as a etiology, the trigger for the autoimmunity could have been a viral infection, right? So antiviral treatment or getting to know the virus will not help in the treatment of the patient, but that could have been the start point or the trigger for initiating the autoimmunity. That's what Dr. Sitharaman is trying to say.
No, sir. Initially, we did all the investigations and excluded all the secondary causes of Evans syndrome. So we won't get any further information by repeating the bone marrow examination. No, sir. With treatment, every time with treatment, the platelet and hemoglobin rose. So
even a transient response to immunosuppressive therapy sometimes acts as a proxy marker for the diagnosis of immune cytopenia. So particularly true in patients in whom we are not doing an extensive workup, like largely for pediatric patients, we don't go for such extensive workup and we assume that isolated thrombocytopenia is immune. But a response to treatment often encourages the diagnosis that this is immune in pathology. Otherwise, response with IVIG or response with steroids is something that we would not expect for like many of the other diagnoses that would be there. PNH, yes, I agree. PNH forms like if you look at the clinical picture, then you can explain the entire clinical picture probably with PNH also. But the response to immunosuppressive therapy with PNH is largely absent. There is you would require complement inhibitors like eculizumab, ravulizumab in providing a like response to the hemolysis in PNH, whereas steroids, rituximab, IVIG, those drugs will absolutely not work. So even the American Society of Hematology guidelines state that requiring a bone marrow examination or requiring extensive workup may not be essential if a patient is showing response to immunosuppressive treatment. You can take the response as a marker that this is immune cytopenia. It's actually showing response but with multiple recurrences. So, so when we offered the splenectomy to this patient, I had this exact same regret that probably at the second or third recurrence, this should have been a consideration. And to that, I'll be honest to admit that, like, you know, relatively younger guys like us tend to focus more on the novel drugs which are available. Splenectomy maybe 20 or 30 years ago was second line or third line treatment in such a setting. But gradually it has fallen down the list, probably wisely or unwisely, I don't know. But that was something that in hindsight, I also thought that probably when he was a little bit stable with the initial response, a splenectomy could have like avoided like a more critical situation. Yes.
Yeah, I think I agree with Naveen. Splenectomy we don't do very lightly these days because long-term consequences of splenectomy are now emerging, and we do it only as a last resort.
So we convened a multidisciplinary team meeting involving anesthesia and surgical gastroenterology. The central challenge we faced was straightforward but daunting. How do we pull off major surgery in a patient with severe refractory anemia and thrombocytopenia? Now I would like to call upon Dr. Ananya Dutt from the Department of Anesthesia to take the case forward.
So we are already 5 minutes over 10, so we need to hurry up.
Thank you, Dr. Gaurav. Good morning, respected dignitaries, respected teachers, and my dear fellow colleagues. I'm going to be discussing about the anesthetic concerns, goals, and intraoperative anesthetic management related to the surgery. Starting with the pre-anesthetic checkup, the patient was a 49-year-old male who was sent to us by the Department of Surgical Gastroenterology with the diagnosis of Evans syndrome, that is autoimmune hemolytic anemia with immune thrombocytopenia, planned for open splenectomy. He was conscious, oriented, and cooperative at the time of assessment. On examination, the patient was vitally stable. However, generalized fatigue were noted along with pallor, consistent with severe thrombocytopenia. He was a known case of type 2 diabetes mellitus since 7 years and was on oral hypoglycemic agent, a known case of COPD since 5 years. The rest of the systemic examination was unremarkable, and the patient was classified as American Society of Anesthesiology physical status grade 3. Patient was advised preoperatively incentive spirometry and deep breathing exercises. The major anesthetic challenges in this patient included severe anemia with hemoglobin as low as 6.4 gram per deciliter, critical thrombocytopenia with platelets equal to 3000 per microliter, perioperative glucose control, unanticipated blood loss with likelihood of hemodynamic instability, and the requirement for major abdominal surgery. Accordingly, the preoperative anesthetic goals focused on optimal hematologic preparation with preoperative platelet transfusion prior to induction, cross-matching of multiple packed red blood cell units, and ensuring availability of platelets. Critical thrombocytopenia increased bleeding risk, requiring atraumatic airway and vascular access. Perioperatively, blood glucose was targeted between 140 and 180 per deciliter. In terms of operating theatre preparation, as already mentioned, adequate blood products were arranged in advance. Single donor platelet transfusion was planned. A difficult airway cart was kept available in anticipation of potential airway challenges. Ultrasound guidance was prepared for securing reliable vascular access, and active warming devices were arranged to maintain normothermia. Invasive monitoring was planned to allow continuous and accurate assessment of hemodynamic status. On arrival to operation theatre, all sign-in protocols were done and baseline hemodynamics were attached. After connecting all baseline hemodynamic monitoring, induction of anesthesia was done. Patient was pre-oxygenated with 100% oxygen for 3 minutes, and then pre-medication, injection midazolam, injection glycopyrrolate, and injection fentanyl was given. Induction agent, injection propofol was given, followed by injection vecuronium for neuromuscular blockade. Intubation was unanticipatedly difficult. A higher Cormack-Lehan grade was noted on direct laryngoscopy, and the trachea was successfully intubated using a video laryngoscope with bougie guidance and an 8 mm endotracheal tube, and anesthesia was maintained under inhalational agent isoflurane. The patient was closely monitored for hemodynamic stability, ongoing blood loss, and transfusion requirements. After induction, in view of the anticipated major blood loss and need for beat-to-beat blood pressure monitoring, an arterial line was secured. A central venous line was also inserted to facilitate rapid fluid and blood product administration as well as for central venous access. Both the arterial and central venous lines were placed under ultrasound guidance to minimize complications and reduce the risk of bleeding, especially in view of the patient's severe thrombocytopenia. During line placement, single donor platelet transfusion was continued to reduce the risk of procedure-related bleeding. Intraoperatively, anesthetic management focused on maintaining physiological stability. Lung protective ventilation strategies were used to prevent ventilator-induced lung injury. Continuous invasive hemodynamic monitoring was employed for early detection and prompt management of fluctuations. Normothermia was actively maintained throughout the procedure. Blood glucose levels were closely monitored and optimized. Fluid therapy was administered judiciously using a goal-directed approach to avoid both hypovolemia and fluid overload. Following splenectomy, a single donor platelet transfusion was administered to address severe thrombocytopenia. At the end of the procedure, neuromuscular blockade was reversed using injections of Gammadex. Adequate spontaneous respiration was achieved, and the patient was assessed to be hemodynamically stable. After ensuring full reversal, adequate airway reflexes, and satisfactory respiratory effort, the patient was extubated smoothly. Post-extubation, patient was fully conscious and following commands. Vital parameters remained stable, and the patient was shifted to ICU from the operating theatre in a stable condition for further observation. For post-operative analgesia, a fentanyl transdermal patch was applied to the patient's chest. Now I would like to call Dr. Akshat to take the case forward. Thank you.
Good morning, everyone. So to summarize, we have a case of Evans syndrome, critically low platelet count of 3000 per microliters, and the planned procedure was open splenectomy. And the reasons were life-threatening anemia and thrombocytopenia, refractory to medical therapy. Challenges were anticipated diffuse oozing from subcutaneous space and sphenic capsule, fibrous sphenic capsule, and difficulty in achieving safe hazard control. Why was open splenectomy done and not laparoscopic? Patient was a known case of COPD. There were anticipated dense perisplenic and hilar adhesions, a need for early and secure vascular control, and ability to manage sudden massive hemorrhage. Also, at a critically low platelet count of 3000, any pneumoperitoneum would mask ongoing bleeding from subcutaneous plane or any peripheral layers of the abdomen. Intraoperative findings were moderate splenomegaly was noted, and there were adhesions present around the splenic hilum and the capsule. There was mild oozing from the splenic capsule noted intraoperatively. This was the taken out spleen, which has been congested after the arterial ligation, and there was a moderate splenomegaly of size around 15 by 16 centimeter. In the post-operative period, patient was kept in the ICU for 2 days for the monitoring and observation for bleeding. Early ambulation was done and oral diet was started by post-operative day 2. Drain was removed on the day 4 with no evidence of any bleeding. Splenectomy vaccination was done before discharge. Patient had an uneventful post-operative course with mild reactionary leukocytosis reaching up to 15,000 and platelets showing a mild response increasing from 3,000 to 5,000. I'd like to call Dr. Neha from Oncopath to discuss on the specimen.
So splenectomy specimen was received in our department of oncopathology. So basically, this is a H&E stained image where the splenic tissue is showing expansion of the red pulp and this atrophy of the white pulp, and we can also see in the background hemosiderin laden macrophages and hematopoietic elements, and there is no granuloma and malignancy seen in this in the sections examined. Now I would like to call upon Dr. Ananya Dutt for further discussion.
No further discussion, is quickly to conclude. Good morning. So what the case was, it was an year-long relentless refractory cytopenia, Evans syndrome, that fell from a standard course to an salvage of splenectomy. This incidence, the females more than males for any other autoimmune cytopenias, the median age of 5th to 6th decades in life. It has a chronic lapse in behavior in 40% of cases. So why did we take this case for a CCR? Because the patient had a year-long clinical battle, failed multiple lines of therapy. He was drained out of resources, drained out of motivation. We were drained out of resources and motivation. Transient fluctuating responses, ultimately leading to a no response. Patient was diabetic steroids, hyperglycemic phase, doing a major surgery in a hemodynamically and hemostatically challenged patient. Compromised patient was a big challenge for us. There is going to be a lifetime risk of OPSI, as previously mentioned by the board here. So, why splenectomy? The rationale is both therapeutic and diagnostic. We got the specimen, we excluded any hidden malignancies from it. So, to answer the previous question, why splenectomy was not offered previously, probably we read too much into the guidelines. The guidelines say that more than 12 months of therapy, splenectomy is an option. Splenectomy is not an option, less than 12 months of therapy, because ITP or AIHA has been known to have a spontaneous remission till 1 year of the occurrence. So probably that was the reason why we did not offer splenectomy before it. So post-surgical course, what happened later? The bleeding stopped, hemoglobin stabilized. There was no immediate platelet increment. However, the patient was discharged at a clinically stable state. Vaccination initiated, penicillin prophylaxis begun, kept under monitoring. Currently the patient is stable, hemoglobin is hovering somewhere between 12 to 14 without any transfusions. There is thrombocytosis, there is leukocytosis secondary to splenectomy. Steroid has been tapered off and stopped. L-Trombopac, the thrombopatic reagent, has also been stopped. We are in the middle of MMF tapering. So surgery occurred in the later August, off steroids by 1st October, off L-Trombopac by end of October, in the middle of MMF tapering. Probably we intend to stop MMF by next month. So autoimmune cytopenias are the major reasons for the splenectomies. We have an 80 to 70% of response rates. The early response rates are much higher. There is a relapse of 10 to 15%. The predictors for splenectomies probably are the IVIG and rituximab. A failure to give a response to IVIG and rituximab is going to non-favor the response to a splenectomy. So Indian data says that 15% have splenectomies occur for autoimmune cytopenias. So long-term data says that 70% initial response rate, 30 to 40% of people would relapse. So we are probably eyeing for something called as a fragile durability of these responses. So take-home message from here is that Evans syndrome can follow a prolonged refractory courses. Repeated transient responses would indicate a biological refractoriness, and that would require a multimodal escalating therapy, something that would lead to a salvage splenectomy. So splenectomy is a major surgery with a risk of OPSI. We might have our own views on OPSI, but the data does say that it's a 15 to 20% of peri-op morbidity would be because of splenectomies. So the clinical judgment, timing and multidisciplinary coordination are critical to these successes. The case reinforces that standardized, individualized, and as said by Dr. Naveen, united by unique, that every patient has to be personalized with therapy, and we probably have to think more of clinical trajectory that would outweigh the lab-oriented algorithmic pathways. Thank you. I take this moment also to thank the Emeritus Chairperson, the MGUMST management, the CCR Review Committee for giving us an opportunity, the collaborating departments, Department of Surgical Gastroenterology, Oncopathology, Anaesthesiology, Medical Gastro, Immunohematology and Endocrinology, nursing officers and the staff, and on behalf of Hematology Department, I thank all of you, and most importantly the patient and his family. Thank you one and all.